I missed the first question on the recording. I apologize, I just turned it on. So, a toddler playing outside gets a laceration on his forearm and he needs stitches. Well, if you have a toddler, ages 1 to 3, needs to get a needle, needs to get all of this stuff going on, how are you going to get that kid to sit there in order to take the stitches, right? That's the big question. Well, if we make it number, right? So they feel touched, pain, and then child life. Now, child life came into fruition about the late like 2010. And when they first came out, I didn't understand it at all. And I thought, why are they in my children's room? Well, what are they doing? What are they teaching? And then I learned. Come to find out, I absolutely love child life. They are educated, very well educated, a minimum of a bachelor degree in growth and development. So when they're talking to these children and teaching them IVs and stitches and things that are going to happen, it's all on their developmental levels. So childlike distraction tells them what they're doing. And I'm telling you, you put those two together and then you put that child on the mother's lap and let them hold. Gee, that's golden. And they'll get their stitches and it's not going to be that bad. A parent recognizes that their toddler has a speech delay compared to their older siblings. What's your priority here? Speech problem. What do you worry about? First thing you check, right? It's all about check their hearing. Speech, hearing together. Very good. Multi. What are signs of an early indicator of impaired cognition? So, cognition is the way you think. It could be with children, they show you by the way that they babble or talk or not. Fine, gross motors. When they're delayed, this is telling us we need to do an early intervention of some sort, right? Whether to get testing or to speech, physical, occupational therapy. So you have to know your developmental stages, right? By 1, they should be saying 1 word. By 7 months, they should voluntarily grasp something. And why do you think a child with impaired cognition has behavior difficulties? They can't express themselves. They can't tell you what they want or need. And then they start throwing things and hitting and screaming. And that I do. I couldn't explain myself, right? So that's why, remember, impaired cognition, you'll always see behavior difficulties. That's what you see in autism too, right? They can't express themselves. A child is being treated for a fever. The reason for treating the child's fever is what? And everybody thinks fevers are dangerous. Once you have a fever, you're actually pretty safe. What happens is when you have no fever and then go to a fever from 98 to 102 in 30 minutes, and that rate of rise sparks the brain and causes a seizure. Now, why do we treat a fever for you? Because you don't feel good. You feel miserable. Children, you give them their acetaminophen, their ibuprofen. 20 minutes later, they're up, they're playing, they're drinking, they need the fluid, they need to eat, and that's that relief of discomfort. And then once they sit in the corner again, the fever's going up. Get them something else. A multi. A child's complaining of something in their eye causing tearing and pain. What do you think you need to do? So when there's something in their eye, there's specific guidelines. If it's floating, you can take a tissue and grab it. If it's in there and stuck, you need to leave it alone. Yeah, you're going to check that pupil for reaction just to see the severity of that penetrating whatever's in there. But we take what we call a Fox shield, and a Fox shield is hard. So it doesn't lay against the eye. It's rounded, it's hard. It'll push there like with a gauze, but it holds it and protects it till they can get to the pediatric ophthalmologist or to emergency room to take care of it. Leave it alone. Don't touch it ever. Separation and anxiety in a child hospitalized. Which behavior indicates the stage of despair? Remember, there's three stages. Remember the first, they're screaming and yelling, and then they regress, and then they don't care if mommy comes. One, two, three stages. Now, that middle stage is despair. We've gone through going, crying, screaming, yelling, oh, mommy, 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 and nobody comes. And that breaks us nurses' hearts when that happens. But it's reality. Parents do have to go home. You can't fault them. There's other children, work, other things to do. Then what happens is they realize, oh, they're not coming. They start sucking their finger, they become incontinent, and they just become very quiet like. It's that regressive, that quiet behavior. And then, of course, that third stage is, nope, mom, you're not here. I'm not looking at you because you left me and I know you're leaving me again and I don't want to get hurt again. So those are those three stages. A child with a history of abuse, which therapy explores emotional problems. So there's all therapies and there's all sorts of plays, right? So which one goes just into emotional? That is called play. All right. That's showing me this is what's going on. It could show a brother or sister or hitting or a friend or a neighbor. So there's all different things that it can show. When it comes to things that happen in a hospital, we do more of dramatic play. Maybe it was they went to the x-ray department and they were afraid of the machines, or maybe an IV, some sort of thing that's they're really upset. They're afraid and they're nervous and anxious. Dramatic play will find out where it is and try to help them. Say, can children react to the stress and anxiety of hospitalization? You found out, I have to go into the hospital and get my tonsils and adenoids removed. And I'm 5 years old. Of course, you got to tell me before I'm going to go. So when am I going to be upset? And the answer is before, during, and after. All of it. Children don't know what to expect. And they don't, after they go home, they're like, oh my God, this all happened to me. And now they're left with a sore throat. So it's anytime. A multi. An adolescent goes to the ER for treatment without the parents. How do you get consent for treatment? Now, this question is a HIPAA question because on your NCLEX, you always have some sort of HIPAA question. And one of the best HIPAA questions is a pediatric HIPAA question. Now, if you have a child who is 18 years old, they can sign their own consent as long as they're alert and they're cognitively aware. If you have to do treatment and it's emergent, you can just go ahead and do it. And when they get the consent is when the child's stable enough to do it. Now, sometimes they come in and they can call the parent and they can get a two witness consent, and that can work too. So, knowing your consents, also be careful. 18-year-olds, you got to ask that child if you can tell their parents what's going on and what labs are because they're 18, they're legal. It's a HIPAA problem. A child is extremely fearful of hospitalization. What types of play explores these fears? And yes, that is a dramatic play. Very good. When checking an IV on an infant, you notice that the tissue around the IV is swollen. What do you do first? Now, remember, infants, 30 mLs of fluids infiltrate is a lot. For me, it's not, but for a little 10-pound child, it is. And it can swell up and cause a lot of problems. Number one, no matter what, if you are even thinking it could be not working right, stop the infusion, check it out, and then do what you have to do. Take it out, start a new one, flush it, retape it, whatever has to be done. In helping a child to adapt to a hospitalization experience, the best approach is what? So you're bringing your kid to the hospital, they're going to be staying there a couple days. How are you going to make their experience better? And again, it's routine. It's not the things, it's actually routines. Now, I'm not saying bringing toys, bringing their blanket, their jammies, those things. Yes, those transitional objects do help, but it's more about establishing that routine. That's the important part, especially on the young toddler preschoolers. Those are things that are important. When assessing vision on a child, each healthcare provider would use a Snellen chart at what distance? This is your health assessment question. You're going to see how they're all feed together. And yes, it is 20 feet. Are you going to use letters on a 3-year-old? No. You might have cats. You might have arrows pointing up or down or sideways. Whatever developmentally appropriate for that child would be the type of chart you use. There's all types. A multi. Nursing care of discharging a child to home. What's your responsibility? You know, the one things I'll tell you about this question here is the one thing that we tend to forget is that children at young ages understand and can be held responsible for their care at home. So provide instructions only to parents? Nope. Some of the children need it too. Adolescents and school age children, even some preschoolers know what's going on. No, they can be a help. Of course, what are you expected? Are you expecting it to bleed or to ooze or to do nothing? Emergency phone numbers. And of course, let them say, okay, tell me what you need to do to take care of your child. Let them, reverb it back to you. What is a 3-year-old's biggest stressor of being hospitalized? I mean, all of these things, absolutely. What's the biggest? I mean, if I said to select all, what are stressors, I'd pick all of them. But when you're talking about 3-year-olds, that's that transition toddler preschooler. They do not want to be away from mommy, daddy, caregiver, whoever it is, that's their significant person. It really stresses them. So when they're separated, that is the biggest stress. Try to keep them with them as much as possible. Multi. What is the best way to alleviate the stress and anxiety of a hospital child? And we've mentioned some things. Now, put them all together. The one thing that we don't do, and I'm glad nobody checked it, is any invasive procedures in a child's room. What they feel, and just to reemphasize that, their room is their safe place. Their bed is their safe place. Nothing bad's going to happen there. So they can rest and sleep and not be worried. You would take them out to any treatment room, etc., to do something that could procedures, even IV starts. Get them out of their room, keep it safe. But yes, keep them on their routine, keep the parents, and of course, developmentally appropriate to talk to them and show them things. A nurse notes a string tied around an infant's wrist. An appropriate nursing intervention would be what? Being a nurse, I've seen all of these little symbols and items that parents give children to protect them from quote evil spirits and whatnot. In fact, they've even given me like the little cat's eye thing, which is this little thing with an eye. I don't know how to describe it, just a little piece of jewelry. But what they do is they put it on their infants, just like a wristband or string. and it protects them. It's their cultural belief. So we're not going to remove that unless it's creating a problem for the child. There's an IV there, it's swollen, it's occluding circulation. Of course, you're going to remove it, but find out what does it mean and then pass that on, write a note so people know not just to cut it off. How can a hearing impairment develop? Anything. Right? I think just sound of music sometimes too loud can hurt the ears, but can be at birth. Those chronic ear infections, that's a big thing. And the illness, there are some Tay-Sachs disease and stuff that clog them up that can cause it. But yes, it can come from an illness. Which urine collection method on an infant is most accurate? Well, why do you want an accurate urine collection on an infant? Infants are immunosuppressed. You need accurate information the first time to get the correct antibiotic delivered the first time. So, which one gives you the most accurate urine specimen? And that's a straight calf. And you're like, but boy, that's a little bit aggressive on a poor little baby, right? Well, if you do it right, you have the mother holding the hands, you're sucking a pacifier, the nurse holds the arms, it's in and out, and you've got the best specimen. And now you can put them on the antibiotic, which will help the infection go away, and you've saved their kidneys, right? You've saved urosepsis. So straight calf. Now, do you need to do that after the age of 1? No. Then we can do urine bags or cotton balls, depending on physicians, but usually put a bag on. I've seen parents take their child and clean the area, hold them over a sink and get a cup and try to catch it midstream. I've seen so many ways to catch it. It can be used, but as I said, infants, we're going to put them on a straight calf. What if you need to just do a sugar or a ketone test on an infant? Would you calf them for that? No. Put a cotton ball in their diaper and it will collect urine in it. You put it in a syringe, push it in, and it will put a drop out. You put it on the strip, and you got your glucose. You got your proteins, ketones, whatever's going on. Okay. So there's different ways of collecting urine, but now you know them all. A multi. What is the purpose and function of the family? Well, with pediatrics, this is important, right? What did the family do for that child? I mean, I think the one thing you've heard from me is transmitting values, attitudes, beliefs. That all comes from the family. Has nothing to do with finances. That's like not really the purpose. Yeah, we want it, but providing that safe environment for growth and development means they're getting what they need. And of course, emotional comfort. The primary goal in caring for the child with cognitive impairment is to what? Again, they're delayed. What do I need to do? Just because a child has Down syndrome, cerebral palsy, does that mean that we're not going to teach, educate, and try to get them to be the best they can be? And the answer is no. We want them to be everything they possibly can be. I've seen very severe Downs, autistic, combined together children that has been taught how to follow routines, and to sit down and not to be this, disruptive part of a group. So you can teach. You got to be safe with them, but promote them to be everything they possibly can be. Because once you do that, you're going to ask for more. Many infants require oxygen. Type is best tolerated and accurately delivered. Now, this is a lecture about variations, right? We don't use these things, this thing of that picture on adults, but we do use them on infants, and they are amazing. It's clear, they can see, they can put their hands, they can suck on a pacifier. If you have a nasal cannula on an infant, do you know what infants do? We have to tape them on to hold them there. They take their finger up and they rip them off and they rip in their skin and it tickles and the air's blowing. so it's not really tolerated. Now, that oxy hood, there's a little sensor in there, you know exactly how much oxygen is, and the kids do really well with it. What is the best practice for school-age children with special needs? Being an older person and being a nurse for many, many years, I've seen so many changes, and even the way that we deal with special needs children. I had the opportunity as a high school kid to work with these children in swimming and teaching them how to swim. And I did it for many, many, many years. Well, what they used to do is they took children with special needs and they put them in a special classroom. And they had a special needs classroom teacher, right? Today, there are children like one of my good friends whose daughter was born who cannot speak. She had a stroke on her speech center at birth. She is the smartest girl you know. Would it behoove her to go to a special needs classroom? No. They're integrated now into regular classrooms, hearing problems, seeing problems, speech problems. These things are now, as long as they're cognitively where they need to be, they're put, and they do really well in a regular classroom. A multi, collecting a heel stick blood specimen on an infant. Well, we don't collect sticks on adults, do we? So this again is another variation, and we need to know how to do it without hurting that child. Remember at the back of the heel, there's a bone, the calcaneus bone. So we're never going to hit that. And the one couple things that I saw with these doing heel sticks, if you warm them up with an approved hospital warmer, don't use a hot towel from the sink or anything. A hospital approved because infants burn quick. Put it on there, warm it up, hold it down, use the proper lancet that doesn't go too deep to get to that calcaneus bone, and it's on the outside of the heel. So not the inside, be on the outside of the heel. Either side is okay. And then put the leg down below the heart. Very easily squeeze it. Do you know how much blood it takes to do a CBC and a complete chemical profile? 1.2 mLs. It's hardly anything. So very slowly, it's actually two little containers you put them in, and it does very well. Referrals for cognitive impairment should occur when? So I'm delayed, speech delay. Physically, my gross motors isn't where it should be. I'm not with a pincer grasp and it's 12 months and I can't do that yet. When are you going to refer that? And that is always as soon as you see it. And then what are types of referrals that we see? Speech, physical, occupational therapy. Yes, we're going to try to rule out maybe the reasons why. If we already know a reason, then of course, putting the therapy in. The best thing about children is when you give them therapy and you give them that little extra help, they're like little sponges. They suck it up and they learn so quick. And it's amazing to watch a child nonverbal and 6 months later, you can't shut them up. It is wonderful. And it's some of the things in pediatrics that I have loved watching. Down's children have frequent upper respiratory infections. Why do you think that? I mean, they have all of these things here, but it's just the one that you think would cause most problems in getting the mucus out so they don't drip into the lungs and create all that. It's that flat, underdeveloped nasal bone. The mucus gets stuck there. They can't blow it out, and it sits and it drips, and then there's that cough, and all that mucus goes into the ears and everything. So another multi. What would be included in the care plan of a patient with moderate cognitive impairment? I think you can see this all of these concepts that I keep going over and over again. Daily structured schedule, and then appropriate, age appropriate toys. One of the things you have to be very careful about, especially with cognitive delayed, like autistic children, is safety. Small items go in the mouth, they inhale them, and their airways choke off. You've got to be careful with the types of toys. So if they're 3, doesn't mean that a 3-year-old toy will be appropriate. Be careful. And again, select things that are going to teach the child something. Something that's play, which made fun, can now teach them a skill. The other thing, cognitive delayed children, especially autistic, sometimes textures, touch, sound, noise bothers them. So you've got to expose them slowly to all of those so that they become aware and accustomed to them. Because sometimes when they get those sounds or those sights, they tend to shut down and scream, and they can't handle it. So again, slowly introduce those things. A multi. Autistic children demonstrate which behaviors? So, cognitively delayed children is also an autistic child as part of that. So, which ones of these here's? Well, I would also say you're going to have they're going to be emotionally have moments. They're going to have what they can't express themselves. So, absolutely. Now, these are all your fine motor, gross motor things, right? Language delays, they're not gonna be talking the way that they should. These are children even at age 4 sitting by themselves. They're not, parallel play. They're solitary. They're alone in the corner. They don't want people around there. They do not look at you in the eye. You sitting there and talking to them, they don't like looking at your eye. And these are children, you can call them by their name, and they don't answer. And then, of course, we know that there's gonna be, the difficulties with, the way that they handle themselves because they can express the way that they're feeling. Again, they do really well on structure routine. Multi. Children with autism have better outcomes if so, structured routine, absolutely, that's key. And then teach them a way to communicate. It could be a board with pictures or some sort of, electronic device. I've had children that were cerebral palsy couldn't speak, and they had little pads that they can show us what's going on. And then, of course, just because they are cognitively delayed with whatever, you never accept unacceptable behaviors. If they did something wrong, they will be corrected. But again, explaining to them what they did wrong and what they're going to do. Like as in a timeout, you're going to sit here because you did this. You're going to, the clock starts, when you're quiet. And you'd be surprised these children who really very autistic, even autistic down children, um, that child, very, very severe, he knew how to come and sit down, and he knew things he couldn't do. Now, why don't you only do licensed therapists? What about mommy, daddy, brother, sister, aunt, uncle, grandma, grandpa? All of everybody can, as long as they've been told what to do. I mean, that's part of what play is, isn't it? It's part of the therapy. A multi. Fragile X causes. Now, Fragile X is the second most common cognitive delay next to Down syndrome. It is so similar, but Fragile X has a lot of conditions where it requires medication because they're very aggressive. It's hard to control them. They act out violently. Now, they are intellectually disabled. They do have learning disabilities. And that aggression, they usually get on like Tegretol medications, serious medications to calm them down, and they have like big ears, small chin, long face. There's different physical deformities like Downs. It's not the same at all, but different, but there are physical deformities. Causes of autism. Boy, wouldn't we like to know what that is. That'd be one thing in my lifetime that I'd like to see gone. What do we do? We don't know. I had one nurse that I worked with who had 2 boys a year apart, and they both had autism. and then she accidentally got pregnant, had a little girl, and she's fine. But, watching her and her struggles and getting care, um, I'd love to cure it. Ways children with hearing impairments communicate with each other. Have you ever seen kids sit down next to each other on different languages and they can play and it's like they're speaking the same language, right? They do all of the above. Very good. Okay, eye conditions. Amblyopia. There's three: amblyopia, strabismus, and nystagmus. Now, there's also nearsighted and farsighted. You know what's crazy about the near and the farsighted? Nearsighted, I can't see far, and farsighted, I can't see near. It's opposite. That always, I don't know why they did that. Amblyopia is that lazy eye. One eye sort of is crooked, up, down, sideways, doesn't matter. A muscle is weak. So how do you think we would take care of that? Fix it. Well, this muscle that's weak. How do you fix a weak muscle? Cover the good eye with the good muscle and make that bad eye muscle work. And we'll be doing that. It's usually a couple times a day, leaving it on for a certain amount of time. And that doesn't overwork the muscle, but works it the way that it should. How would you encourage a preschooler to be less apprehensive when taking their vital signs? So when you have a preschooler, their ages 3 to 7, and the first thing is to tell them what they're going to do and explain them. And then, of course, I let them push the buttons. They can play with me. Very good. What child may be more stressed when hospitalized? And you're like, well, what does that mean? Well, you have all children. Children who've been in the hospital before. Some children, are going to go in overnight for all different reasons. Which one's going to have more worries and concerns? And believe it or not, it's that child who's been in there a lot. Because what happens? You're in there a lot. You've had these experiences. They could have had somebody who started an IV and hurt them, or they could have, some bad something happened. And because you have longer amount of time there. So that is the person. A high functioning, no, it's the frequent. A toddler has a hard time fixating on a single point. The child's eyes cross to the midpoint, which means your eyes are working and they cross. They don't get together, which means there's no depth perception. They don't work. What is that called? That is called strabismus. Now, the other eye condition where the eyes, the muscles sort of twitch and wiggle, they call them, it's called nystagmus. So you have amblyopia, which is lazy, strabismus, where the eyes cannot focus, and you have the third, they're wiggling, that's nystagmus. A multi. Safety in administering medications to children include what? Safety in administering medication to anybody is, right? So you're going to calculate the dose, milligrams, micrograms, units per kilo, whatever it is, always using their weight. That's why we do a weight on every time you see children. And also, it is a name band that we look at. Don't ask the child their name. You can't be sure that they're going to give you a right name. And again, room number. We used to say you're in room 203B, go down there. We don't use room numbers as identifiers at all. Times we have to change rooms according to getting a new admission. So it's only proper dose and a name band. What can help parents to make a baby swallow the medication? Baby, toddler, preschooler, you give them the medicine and now they're trying to swallow it. Sometimes infant want to spit it out. I mean, older kids, of course, and they don't want it. But this is something that I used to do, but with infection control today, I teach the parents. And if you get it in their mouth, you squirt it to the side of their mouth, take a deep breath in and go real quick in their face, they go, and they swallow. And that's the trick to get it in. Okay. Treatment for amblyopia involves, like just taught you. What is it? So amblyopia, lazy eye, make that lazy eye work, cover the good eye, make it work. A nurse is discussing sexuality with the parents of an adolescent with cognitive impairment. It's important. So you've got a 14-year-old girl with Down syndrome, and the nurse is telling you, about sexuality. What do you think the nurse needs to tell this parent? Again, remember, we're keeping our children safe in everything we do in pediatrics. It's always worried the child is safe. So what they say is an individual, well-defined, concrete code of sexual conduct. What's good touch? What's bad touch? Who can touch you? Who could touch you where? Those things. And what to do if this happens. Very important to keep our young adolescent girls and boys safe from people that are not very nice. A multi. A child is asking mom about his sibling in the hospital. How can you alleviate his stress and fear? Today you pick up the phone, put it on FaceTime, you can talk to his brother or sister, right? But what if we don't have that availability? So I've done things like I'll make bows. I always have ribbons for my little girls, little babies. And I would always send one home for the sister, or I would find coloring books and crayons and we color a picture if we could, depending on patient condition. All those little things, number one, is not taking care of the brother or sister at home. It's also helping that child in the hospital, making them feel important, like they're having a job to do. Also, if it's possible for them to go in and get a visit, that child needs to be prepared for the sounds, the noise, the machines, where things are sticking out of if they're like in the ICU, okay? Another multi. What are some best practices when a child is in pain? What are you going to do? Well, we know if a kid is in pain, the first thing we're going to do is, find out what the number is, or the faces, and then we're going to be medicating them with whatever medicine it is. Now, before you do anything, move, do respiratory, out of bed, sit in a chair, medicate them for pain first. They're in pain. Then reposition the child. Then give the incentive spirometry, getting them out of bed, walking in the hallway. So they've already had their pain medicine. They'll be able to do it better. Also, distraction, TV, iPads, crayons, cards, whatever. Kids do really well when you do that stuff to them. Takes their mind away from it. A multi. Children can be critically ill for long periods of time. How do you prevent pressure ulcers? And you're thinking children pressure ulcers? Oh, yes. You get some kids that are extremely ill in ICU for months and months and months and months. And it is one of our jobs to keep that child free from getting any sort of pressure marks at all. So what do? We keep them dry, we turn them. We're going to use that draw sheet. And what's really neat with especially little babies and younger kids, parents always bring in stuffy animals and stuff, right? I'll put it underneath their ET tube so that the child can see it if they open their eyes, or I'll have them hugging a teddy bear or between their legs, blankets, animals. As long as it's soft and cuddly, I put it all around them. And actually the parents come in and go, "Oh my God, that baby looks so comfortable. Thank you so much." And now I made that child look less threatening. And last question, multi. Young children can be stressed by being in a hospital. How can you decrease this stress? So I think I've covered, this pretty good. And this is basically the combination of many, many questions today. Same routine, have parents stay there, and then they can bring in their transitional devices, their toys, their favorite little stuffy or their favorite little binky or whatever it is. All of those help. Limiting visitors, no. Usually, the children do want people unless it's, against what's going on with that child, and they can't be disturbed like that, but no, you don't limit. It's the hospital rules that tell you how much usually. Number 3 is a me, Autumn. Good job, Autumn. And number 1, Dan, the man. Good job. Tammy and Keeg. Good job, guys. So, it's your lecture for today. You've gotten all the concepts you need there. Again, you're going to have your grades out by Saturday about 12. I'm telling you, there's nobody with a horrible grade here. So you can all relax. Um, First exam is always harder. It's the theorists that usually catch you. So next exam, you want to meet me before and go over some concepts so you come into the exam stronger. Send me a message and we'll work on a time to work. Now, Thursdays and Fridays are great for me. Um, Usually about 10 to 2, I'm with meetings, but usually after that, I'll be available for anything that you want to go over with. If there's problems with math, I'll let you know. And I'll be sending you stuff out and trying to get a hold of you to do some math tutoring. Thank you guys. Have a great evening. Good job. Really good job on that exam. I'm very happy.